Hello, I am Dr. Richard Boles, and I am going to be talking about ADHD and to some extent about related disorders such as anxiety and autism, and how mitochondrial dysfunction is important in the what causes ADHD and how dietary supplementation can help. I'm going to first start off with a few slides to give you an idea of what it is that I'm talking about, and then I'll give a more formal talk about who I am. First of all, it's important to know that all of these conditions are really just what we call phenotypic descriptions, meaning that they are just simply descriptions of what people have, certain signs and symptoms. You meet so many of them and you have the diagnosis. They really are overlap each other, and it happens, but it's most patients actually have more than one condition at the same time because they're not distinct conditions, but they're really just clusters of symptoms. First of all, I want to mention that ADHD, autism, and anxiety are very closely related. At the top, ADHD is related to many other mental health conditions on the lower right, and on the lower left, it's not just that the descriptions overlap or that people will have the signs and symptoms of more than one, but the genes overlap. The genes that will cause one are, in many cases, the genes that will cause another of these conditions. The first patient I want to talk about is technically an autistic patient, but he really has more than that. Payam has OCD and anxiety. He also has other issues, as you can see from the slide: irritability and aggression, hypotonia, vomiting, but he also has functional problems, the vomiting, constipation, fatigue, insomnia, movement disorder. Genetic sequencing of him found a variant in the creatine transporter. Creatine you might know about from bodybuilders. Creatine is important as a source of energy. It's not just for muscle, but for brain as well. And the creatine transporter is needed to transport creatine from the blood to the brain. With the creatine transporter not working, we tried creatine to see if we can get more in, and it didn't make a difference. And then cyclocreatine was started, which goes across the blood-brain barrier without going through the creatine transporter, and then it's converted to creatine in the brain. On cyclocreatine, Payam had less anxiety, his expressive language improved, his behavioral manifestations improved, he was able to handle change and frustration, better awareness of his environment, improvement in visual attention, more erect posture, and decreased hypotonia. So it did help in many different ways. So you could say that it helped its autistic features, but many of those are also features of ADHD, anxiety, and other what we call neurodevelopmental disorder. And the creatine transporter is important for cellular energy. And so you could say that this is mitochondrial dysfunction because you don't make enough energy in the brain. But this is not a mitochondrial disorder because the creatine transporter is not located in the mitochondria. It's located on the cell membrane to allow creatine to get into the cell at the first place. And this is a good example of you can have mitochondrial dysfunction without a mitochondrial disorder causing a neurodevelopmental condition. The next case is another kid with technically had autism, Carter. He developed it at 1 year of age when he stopped speaking, later diagnosed with autism. Biochemical laboratory testing suggested the possibility of a mitochondrial disorder, and then DNA sequencing revealed a particular variant or mutation on the TRAP1 gene. Now there's this little cartoon in the lower left is the TRAP1 gene, the protein that's made from the gene. There are two different protein molecules there. One's in pink and one is in silver or gray. And you see that they're identical and they attach to each other to make both sides of like a scissor or a claw that grabs onto molecules and holds them there. What TRAP1 is it's a chaperone. It takes proteins where they're supposed to go and that they don't unravel, in other words, do what they're not supposed to do on the way there. The green at the bottom is the ATP, and that's where the mutation is in Carter and many of the other patients that I've seen. And using computer modeling, we looked at every single drug. This was done at Georgia Tech with with colleagues, and to look at in a computer model to see every single possible drug and to find one that would stop the mutant TRAP1 protein. In other words, the protein that is encoded by the mutant gene with the mutation on it, but will allow the wild type or normal protein to work without any problems, because we don't want to turn off the normal, we just want to turn off the abnormal protein. Ganacitron, which is also known as Kytril, is a drug that the computer predicted would do that. And after informed consent, Carter got a lot better, more talkative, clever, focused, less aggressive, less sensory integration issues. He got along much better with his older brother and was more tolerant of previously difficult situations. In fact, that there was a nationwide shortage of Kytril a couple of times, and the insurance company balked at payments a couple of times because they felt that this is way off label. And he was off of it, I'm aware of 5 different times, and each time he did deteriorate. But following him out, that was about 5 years ago. Now his autism is essentially gone. Like a lot of kids, if you find out the cause of their underlying disease, you can improve them greatly. His language, his social skills are much improved. In fact, he's mainstream in about 50% of his classes. What he really has now is ADHD. He's inattentive, impulsive, and hyperactive. And he's on methylphenidate, which is Ritalin or Concerta or Contempta, or some of the brand names for that. And the most recent time that he got off of Kytril, he was off of that and carnitine. They went on a vacation and they left the drug behind. And 3 days later, he had a significant increase in anxiety, attention deficit, and hyperactivity. So his ADHD is attentive to this treatment. It also shows you well, first of all, is that these conditions are all related to each other. And second of all, if you can find the exact cause of why a patient has a disease, then it's oftentimes you can figure out what to do about it. And that sequencing can sometimes seem like magic. And also, my daughter loves to have her picture taken. So here's the introduction. Who am I? Well, mostly I'm a clinician treating patients. For the last 30 years, I've been a geneticist, and the major role that I have, my day job per se, is as a physician seeing patients. I generally take care of patients with neurodevelopmental disorders such as autism, ADHD, epilepsy, etc. But I also see a lot of patients with functional disease such as cyclic vomiting, migraine, chronic fatigue, and those sort of conditions. But I'm here today as the Chief Medical and Scientific Officer of NeuroNeeds. It's a company that I started with 2 others to produce products for people with neurodevelopmental conditions such as ADHD, autism, anxiety, and the others. And then you'll see some of our products at the end of this talk. I'm also been the medical director of DNA sequencing companies in the past, including 5 years at Cortigen Life Sciences, but I no longer have that role. My role now in terms of sequencing is as a client. I order sequencing on my patients. I'm also an expert witness in many legal cases, particularly involved in child abuse, neglect, Munchausen type things, and also on the vaccine court. And then I'm a researcher. I was 20 years as USC faculty, University of Southern California, and I had prior NIH and foundation funding, and I still occasionally write scientific papers. Some of the disclosures here, what I'm going to be talking about is personalized medicine. In personalized medicine, the treatments are off-label because they're based upon the individual genetics of a person. So the Kytril that I used in that one patient and the cyclocreatine, which is used in another patient, are not approved by the FDA for those uses. Those uses were determined based upon analysis of the genes in that patient. They were the first ones, as far as I know, in the world that were tried on those treatments for those reasons. So any of the treatments I'm going to be talking about throughout this entire talk are off-label, and it is my legal duty to disclose that. Also, I am the Chief Medical and Scientific Officer of NeuroNeeds, and we design products for many of the conditions that we're going to be discussing here, so there's a conflict of interest. And also, I'm talking about genetic testing. I use genetic testing quite frequently in my own practice. In fact, I do it for all my patients. But at this point, there's no official recommendations regarding genetic testing, and the type of testing I do in my patients are my own opinion as to what I think is best for their care. Okay, many of you probably know the ADHD criteria backwards and forwards, and some of you may have just been given the diagnosis and don't really know what that means. Like almost all diagnostic criteria, it's based upon having this, this, and that, and not having this, this, and that. Inattention is the first thing. You have to have 6 or more of those in a child, 5 or more in 17 years old or older. And you can kind of look at some of the greens there as to what, these are actually the official recommendations. The color highlighting is mine. And if you if you meet criteria for that, but you don't have what's on the next page, then you have the predominantly inattentive. It means you have inattention, but not the hyperactivity or the impulsivity. But if you have the combined presentation, not ADD, but ADHD, to add the H in there, you have hyperactivity and impulsivity. And in kids, they may climb things and fidget and be out of their chair a lot, talk all the time, blurt out answers. In adolescents and adults, it's at a more appropriate developmental level. They won't climb trees and things like that the younger kids will, but they will be always on the go and, fidgeting and moving around and talking about different things. So if you have the ones on both slides here, that's the combined. And then there's caveats and everything. You have to have had the symptoms prior to age 12 years. This is something that occurs developmentally. This occurs in childhood. It has to be in 2 or more settings. If it only happens at home and the child does perfect at school, that's not ADHD. That's more of a behavioral issue. Usually in kids, it's home and school. With adults, it would be home and work, but there's other combinations. It has to be severe enough to affect functioning, not just somebody who's the class clown that everyone likes. It seems to be all over the place. But if they're functioning normal in life and enjoying themselves, they don't have a disease. They're not diseased. It has to affect their functioning. And then, of course, it's not better explained by another mental disorder. And as I mentioned before, a lot of people will have criteria for more than one of them. And it's okay to have the diagnosis of more than one, because it doesn't mean you have different diseases. It just means that the brain disorder that person has meets the criteria for more than one condition. And it's really important to understand that ADHD is common. It's the most common of all of the neurodevelopmental conditions. The estimates between 5 and 7% of children, 2.5% to 5% of adults. If you use the smaller numbers there, 5 and 2.5%, that means in the United States, 4 million children and 6 million adults are affected, most of which, particularly among the adults, do not know it and are not treated. But it affects their life in many different ways. Now, I've showed you most of this slide before. It's very important to understand that ADHD is just part of a much larger neurodevelopmental disorder spectrum. You may have heard of the autistic spectrum. That's a part of that spectrum. The inattention, the hyperactivity, anxiety, conduct, anxiety, depression are all other aspects in the spectrum. In one study, in ADHD, 50%, you can see from the right-hand side there, the numbers in black, 50% had a comorbid condition among those that are listed in the lower right, conduct disorder, anxiety, or depression. 30% had anxiety, 30% had depression. And about 50% were just straight ADHD in that one study. And then, as I mentioned before, the genes overlap. The genes don't only overlap between ADHD and autism, but they also overlap in epilepsy, intellectual disability, schizophrenia, and also metabolic disorders, congenital heart disease, and others. And the conditions in green on the lower bottom of the slide, those are many of the conditions which are known to genetically overlap, meaning the genes that will cause any of those conditions overlap with the genes that will cause any of those other conditions. They also phenotypically overlap in that patients will often have more than one at the same time. So what really is ADHD if it's just part of a spectrum? When somebody has ADHD, it's really saying that their executive function is impaired. Executive function can be looked at in many different ways, but one common way to look at it is working memory, cognitive flexibility, and inhibitory control. The inhibitory control is the one that's most easiest to understand. It's keeping yourself from doing what you feel like you want to do because you feel like you shouldn't do it. It's your superego. It's the ability to avoid the id and just blurt out whatever you feel like doing and just doing whatever you feel like at the time. And that's part of executive function. That's in the prefrontal cortex in the front of the brain. It's the area that myelinates very late in life. It's really not totally active until the late 20s. If anyone's raising adolescents, they probably know that. And it is a major part of it. But there's also cognitive flexibility. That's the ability to change your thinking, to change your approach. If one way is not working, to try another approach instead of just hitting it over and over again, asking the same question, trying the same approach. And then working memory. People with ADHD have difficulty with working memory. They can't keep it all in their head. They just can't remember it. They just don't have it there. They need to have it down like on paper or on a computer or structured environment where they're told to do this and then they're told to do that. They may be brilliant. They may have an extremely high IQ. They may be able to do everything that you ask them to do, but if you ask them to do 3 things, they won't do anything. But they can do one at a time because their memory can only handle one at the time. That's the working memory. It's not what you remember about the past. It's what you can hold in your head at a given time. But this is the one that I prefer. I like the Pooh pathology test. And yes, this is somewhat of a joke. I found this online. But what's the difference between Pooh and Tigger? Well, Pooh has inattentive ADD, and Tigger has combined ADHD. And you can see, Piglet has anxiety disorder. Rabbit's obviously OCD. Eeyore is obviously depression. I guess Roo is autism because he hides in the pouch. And Christopher Robin is schizophrenic because he's dreamt this whole thing and believes he really is talking to all these other creatures. So the Pooh pathology test, you can Google that if you're interested, and you can take it online. These are my individual scores here, and as a scientist, I tend to be more on the autistic and the OCD side, but not severely. And I think that's probably a pretty common profile for someone like me. This slide right here is one of the most important ones on here. You're here because you want to hear about ADHD. You know that it's serious, but it's probably more serious than you think. It's a serious condition, and the approaches to take it need to be serious. It's persistent and markedly impairing, and it's not just that it affects the individual's social life, romantic life, and ability to stay in school and to get a good job. People with ADHD have increased risk for poor outcomes because of their behavior. They have more injuries, traffic accidents. They smoke more, they use more substance, are more likely to be in jail, unemployed, divorce, higher suicide rates, AIDS-related behavior. They have an increased rate of death from many, many causes. They have increased mental health risks, and those are things that we've spoken about before, because these conditions are not necessarily distinct, they're just descriptions. Everything from autism to schizophrenia, bipolar, depressive, antisocial personality, tic disorders, etc. They have a decreased years of schooling, reduced college graduation. And what I didn't know until I put the slide together, they have a decreased age of first child and increased number of children. They tend to have their first child at a much younger age. I guess if you don't have much of a superego, it's sex, drugs, and rock and roll for you. It's, in fact, on the right-hand side there, I took that from a paper, which I really need to put a reference on it. Sorry, I will do that later. And you can see that one of the major is age at first birth is the yellow on the far left side. Its lower age at first birth is way away from the dotted line, which would be the average of the population. But there's increase in smoking, and therefore there's an increase in lung cancer. There's an increase in obesity. And that's really not believed to be due to the fact that they can't say, oh, I don't want another piece of pizza. I don't want another cookie. But there's genetic overlaps for the risk. Many of the genes involved in obesity are genes that are involved in ADHD as well. So it goes beyond just the neurodevelopmental disorders. But you can see that there is a significant risk to this disease. But before you end out all depressed, ADHD is the most treatable of all the neurodevelopmental conditions. So really the slide is to push people to take this disorder seriously and to really embrace treatment. Okay, what do we know about ADHD genetics? I'm a geneticist. I wanted to show this slide here, if you can look at the bar graph. And because all of these studies, over 20 twin studies, are almost exactly identical. One on the far right means it's entirely genetic. There's no environmental component whatsoever. You see that almost all of the studies are about, particularly the most modern studies, you can see the ones at the top are more recent. They're more well done. It's between 0.7 and 0.8. That means that it's about 70 to 80% hereditary. And if you add all those studies together, you get about 75%. So it's about 3/4 is genetic and 1/4 is environment. That is extreme. You will not find another condition, except maybe autism, that's that high in terms of hereditability. If you look at almost anything else, asthma, diabetes, heart disease, you'll get answers of heritability that are more like 20, 30%. This is extremely high, and ADHD really is more than anything a genetic disease. And siblings, if you have ADHD, the sibling is at 9-fold increased of having ADHD than if a child without ADHD, the sibling of a child without ADHD. So you take a child with ADHD and you take a child without ADHD. Look at the brothers, look at the sisters. It's 9-fold, 9 times more likely that the sibling of the ADHD will have it instead of the sibling of the neurotypical or unaffected child. That's a really extreme risk. You say, okay, well, there's 25% environment. What is it? Well, that's a really good question because we can't find it. If you look at adopted relatives, it's the same risk exactly as the relatives of unaffected children. So if you have ADHD, your adopted brother has the same risk of ADHD than if you don't have ADHD, your adopted brother. The risks are not shared. They're probably micro risks that have to do with in utero and factors that are involved in the formation of the brain that are not directly under genetic control. But the environment, at least the shared environment that siblings and other family members share, does not increase the risk whatsoever. When you look at family studies, it looks entirely genetic. But one of the things that's very important to understand here is that the genetic studies have shown that ADHD is not a distinct disorder. It's not people with it and people without it. It's a spectrum. On one side of the spectrum are people that have very, very severe ADHD, like Tigger, and can't do anything practically. And on the other end of the spectrum are people that are very much exactly the opposite, OCD-like perhaps. And it is, where do you draw the line as to when you have disease? It's really an arbitrary line that's based upon when you are diseased. And as society becomes more and more technical, requiring more and more years of education, and that the fruits of your labor depend more on your ability to concentrate and get work done, then more and more of the population is unable to do that, and they're labeled with ADHD. And it's a real problem in them. It's not just that they can't aspire to higher education to the same degree and to get the same degree of employment and remuneration, but it's also that they can't control themselves against many of the fruits of our economy that are constantly trying to take them down the wrong road. Gambling, drugs, alcohol, etc. So it is an issue. Now there have been several genetic studies. These are called GWAS studies. Genome-wise is looking at all of the genome, all of the DNA. And the AS is association study. So it's looking at all 3 billion nucleotides between people with ADHD and people without ADHD. And they're saying, okay, where's the difference? And they looked at 12 studies, and a meta-analysis, you put all the data from the 12 studies together. And I know this slide is complicated, and you see in the genes there in the table, there's the middle column gives the genes which are associated with ADHD. From that study. There are 12 different markers. That means on 12 different chromosomes. Well, there's two of them are on chromosome 1 because it's the largest chromosome. The others are all on different chromosomes that cause risk. If you look at the top one here on chromosome 1, a G, which is just a 1 nucleotide, changes to a GT, so you add a T. So it's only the addition of 1 nucleotide. And this is the important thing here, the odds ratio. This is an 11% risk. It's not like it increases your odds of having ADHD many fold. It just increases it a little bit. Here are the genes which have high risk, and that's what we know about the gene: synapse formation, dopamine levels, embryonic development, the wiring of the brain, cellular recognition. Cells have to recognize to make synapses with each other. Neurons have to. And so these are just to give you some of the idea. These are genes that are involved in building a brain. That's why there's an overlap. That's why these are the same genes in autism, the same genes in schizophrenia, in migraine, in intellectual disability, in seizure disorders, in depression, because these are genes that are involved in building and maintaining a brain. But if you look at these 12 loci, they only capture a tiny fraction of the risk. If you were to sequence all these 12, it would only tell me about 10% of the risk for ADHD. 90% have nothing to do with any of those 12. If you took all common variants, that means there's about 100,000 or so common variants that frequently change between people in the population. If you look at all 100,000 of them, it accounts for about 20% of the risk for ADHD. Now, remember that the risk is really 75% that's genetic. So the difference between 20% and 75% is what is not accounted for in common variants. And therefore, they are likely rare variants. So rare variants, in other words, every person with ADHD probably has different variants which contribute the genetic risk. So you can't just do a test and say you have ADHD or not, because you really need to look at all the genetics and look at it very closely, because the vast majority of the genetics that causes or contributes to ADHD is going to be based on rare variants that are likely seen in only that one family, that one child. Now, some of the rare variants are large variants and some are small. If they're large variants, they're often called copy number variants, because they're either you lose a copy. Remember, everyone has 2 copies of every gene. If you lose a copy, you have a deletion. And if one of the copies is duplicated, so you have 3 copies instead of 2, you've gained. So you normally have 2 copies. If you have a deletion, you have 1 copy. You lost function. You lost, and then you have gain. You have duplication. You have 3 copies. These changes can be thousands of nucleotides, or they can be millions of nucleotides. And they are increased in ADHD. In people with ADHD, they have more copy number variants. But if you look at the copy number variants for hundreds or thousands of patients, what do they tell you? And these are the pathways. The ones in green are metabolic or mitochondrial. And the ones in blue are ion channels. Those are the channels or the holes in the membrane that ions such as sodium, potassium, or calcium go back and forth to change the electrical properties of the membrane. It's how a nerve fires, how a nerve conducts electricity, or how it conducts signals, is by causing ion channels to open and close. Ion channels require a huge amount of energy to operate because you have to pump all that stuff back. And so there are mitochondrial components in the green and in the blue. And we're seeing that in ADHD, that from a theoretical point of view as to what pathways are involved, it highly involves energetic pathways. And then again, as I said, there's a significant overlap. These are the same genes that are in other disorders: autism, schizophrenia, bipolar disorder, and depression. I put those down because studies have shown there's overlap with those conditions. I'm sure that there's overlap with the other conditions. It's just that studies have not shown that yet. But they're really the same genes. It's what's needed to operate, to form, to operate, to maintain a brain. Okay, we're now talking about mito, or mitochondria. So this comes from the United Mitochondrial Disease Foundation. So this is not, I did not copy and paste this from there, but I just looked at the various places on their website, and this is a few years ago, and I wrote down all the things that I could find on there that's associated and put it on one slide. And I did this to show you that everything in green is neuromuscular. Yeah, there are things outside the nerves and the muscle, but it's really neuromuscular disease. And mitochondrial disease is often called encephalomyopathy. Encephalo means brain and myo means muscle. And then I put autistic features here. Autism, which is very similar to ADHD in many different ways. And some people even consider ADHD to be a mild form of autism, is one of the things on their list. But they don't list ADHD. Maybe they have by now. So what do we know about mitochondrial disease? First of all, is that mitochondrial dysfunction is simply what I said, mitochondrial dysfunction. The mitochondria aren't working right. They're not making energy right. That could be because the mitochondria are not working. That's mitochondrial disease. Or it could be something outside of the mitochondria, which is secondary mitochondrial dysfunction. So the one case report I showed you of the creatine transport disorder, that's outside the mitochondria. That's on the outer cell membrane. But it causes the mitochondria not to have enough energy. So it's a secondary mitochondrial dysfunction. The TRAP1 that I showed you in Carter, that causes the mitochondria to have problems inside the mitochondria itself. So that would be called a mitochondrial disease. Really doesn't matter. You'll hear these terms used pretty loosely. But in general, you have less energy. The cells can make less energy. So neuromuscular disease is most common. As I mentioned, it's because nerve and muscle have very high energy requirements. They're electrical in terms of nerve and muscle, but muscle also has to do work. So what do we know about mental health conditions in mitochondrial disease? There have been some papers, and it's about 60% of patients with a diagnosable mitochondrial disease. If they're adults, they have a mental health disorder. And here are the ones that are in the paper here. Many of the same conditions that we've already discussed. Antioxidants are the primary treatment for mitochondrial dysfunction, whether it's a mitochondrial disorder or not. And antioxidants are used in a large variety of brain disorders. And here's just some of them that I found, and then I stopped writing them down here. But everything from Alzheimer's to autism to schizophrenia, depression, substance abuse, OCD, people have used antioxidants often successfully in these conditions. Well, you notice I didn't put ADHD down in here. What about ADHD in mitochondria? ADHD is closely related to autism, depression, and schizophrenia, and other brain disorders. Mitochondrial dysfunction is treated in those conditions with antioxidants. So first question is, are mitochondria abnormal in ADHD? And the second question is, does that help us to figure out how to treat it? I ran out of space here. I want to show you there's a lot of papers that show increased oxidative stress in ADHD. The ones with the green titles are the ones that are more of review, that kind of speak about many of the papers, and then the individual studies are the blue titles. And then there's some that are not colored that are also important. But this shows you that there are a lot of studies out there, and this is the partial list. of oxidative stress at ADHD. If your mitochondria are not working right, you have oxidative stress. Well, what about drug treatment? Drug treatment can be extremely effective in ADHD, and I want to mention that from the onset. But ADHD drug treatment might actually increase oxidative stress. And there's a couple reasons for that. For one, dopamine and other catecholamines like norepinephrine are increased by the drugs. The usual things that are used, such as like Ritalin and amphetamines, increase dopamine. And many of the treatments increase norepinephrine as well. Those neurotransmitters can easily undergo autooxidation, forming reactive oxygen species, which causes oxidative stress. But there are also reports that methylphenidate, and that's Ritalin, Concerta, Contempta, and there's many other names for it, also has an impact on increasing oxidative damage. And here are some of the papers that show that together talk about this. And then the one on here is a review paper. So I'm not trying to discourage the use of the drug treatment in ADHD, but I want to know that it might possibly even further increase oxidative stress. Okay, so in your own child or in yourself, what other signs are there of mitochondrial or metabolic disease in general? And I consider these to be red flags, that these are the type of things that are really common in mitochondrial dysfunction. And if your child has ADHD and has 2 or more of these, then I think that mitochondrial dysfunction is extremely likely. Autistic spectrum disorder, movement disorder, the loss of milestones, any regression, any, like with an illness or a vaccine or a surgical anesthesia or an injury or final exams or any sort of stressor, if they lost abilities, if they had neurological regression, that's probably the most of all the signs that says that, yeah, there's likely to be mitochondrial dysfunction. It's also a sign of an immunological autoimmune type of problem as well. But it can go in either direction or both. But you can see there's a lot of other things here. Muscle disease, like if the eye muscles have trouble moving and the child turns his head instead of his eyes to look around. Cardiomyopathy is rare in ADHD. Bowel dysmotility, chronic constipation, diarrhea, cyclic vomiting, POTS, tachycardia, high heart rate, unexplained fevers, other signs of an autonomic nervous system. Chronic pain is a common one. It can be migraine, it can be muscle pains, chronic fatigue, of course, if your mitochondria aren't working right, mood disorders, anxiety, depression. Those are signs of mitochondrial dysfunction, among other things. Clinical course waxes and wanes. Some days you're better, some days you're worse, particularly if there are like spells of altered mental status or even spells of psychosis in which the child doesn't really understand what's going on and then it snaps out of it. Those are often mitochondrial. Hypoglycemia, metabolic acidosis, elevated liver transaminases like an ALT, AST. So this is, I can't put everything on one slide, but here are some of the ones to think about. We've been talking so far about the nucleus because the nucleus has 99.99% of the genes in it. And the nucleus is in the center of the cell here. You can see the nucleus in the very center of the nerve cell, and this could be any cell here. And the vast majority of the genes are in the nucleus, and here are the chromosomes. They're arranged in the 23 sets of chromosomes. But the mitochondria also have their own DNA. And instead of about 23,000 genes that are in the chromosomes and that they make proteins which then are moved to the nucleus, there are 37 genes in the mitochondria themselves, and they make 13 proteins. The inheritance pattern is the usual inheritance pattern that you've learned in school for nuclear, but in mitochondrial DNA, it's maternal inheritance. So the mitochondrial DNA comes from the egg, not from the sperm. The sperm do not add their mitochondria into the egg, so they're not. So your mitochondrial DNA is exactly the same as your mother, and if you're a woman, you passed it on to all of your children. If you're a man, none of your children have it. So this grandmother here, this just says this mitochondrial DNA, whether it be a great one or a bad one, diseased one, normal, whatever, her mitochondrial DNA of this grandmother on the right-hand side is passed on to the three of her children, her two daughters and her son. Her daughter over on the left one will pass it on to all three of her children, regardless of who the father is. But her son will not pass it on to any of the children. So all of the people in red have exactly the same mitochondrial sequence. So you could say, well, all the people in red should have ADHD perhaps. That never happens. This is a real pedigree. This is because it's very complicated. There's a lot of other genes and there's many other processes going on. Everybody in the family is going to have different disease manifestations, but they're usually neuromuscular disease. Migraine is pretty common, depression, anxiety, but there are many others. To go over another case report really quickly, William presented to me at age 6 years. He had typical mitochondrial problems. He had pain, muscle fatigue, constipation, but he was an excellent student. Mitochondrial disease was suggested by looking at a biopsy and muscle biopsy, and his pedigree was that of maternal inheritance. It followed a similar to inheritance pattern to the one that I just showed you. He had mitochondrial DNA sequencing revealed that he had a mutation, 55% mutation. That means 45% of the mitochondrial DNA had the normal sequence and 55% had the abnormal sequence. This is common with a severe mutation. 100% is not compatible with life. People with disease have lesser amounts. It's in a gene for complex 3. His mother was also affected. She had 78%. He was put on mitochondrial cocktail. He got much better. His headache, muscle cramps, and abdominal pain all went away. But what does it have to do with the talk on ADHD and anxiety? Well, his little sister came to me a few years later. She was also 6 years when she came to me years later. She had really severe anxiety that came up suddenly at age 5. She couldn't get her teeth cleaned. She couldn't go to birthday parties. She could not do scouting or gymnastics. She would randomly cry over half the day, any changes to the routine whatsoever. She had severe separation anxiety. She could not go to kindergarten. Her mother had to be in the class, in the room, and with her in the restroom all the time. She wouldn't even be with other people, other relatives. She also had a chronic right ankle pain, which was there every day, had x-rays, MRIs. No one could figure out what it was. We did the DNA sequencing, found out that she had the same mutation, put her on a mitochondrial cocktail, and yes, she was put on Zoloft, but very low dose. Her anxiety and her pain completely resolved. She had the pain for 3 years, and it wouldn't go away. And the anxiety was about a year, and they completely resolved on the cocktail and low-dose Zoloft. It really shows you is that how diagnosis can be important and how treatment can make a difference. Okay, this is my thing to step back. I've been talking straight for 45 minutes. Just kind of enjoy the scenery a little bit. This is my daughter earlier this year. And this is the super bloom in the California desert just over a year ago. We don't have it this year. So treatment, we're talking about a cocktail. But alcohol is a mitochondrial toxin, not a mitochondrial treatment. So we're talking about cocktails without alcohol, unfortunately. Here's the general principles of treating in mitochondrial medicine, whether it's mitochondrial dysfunction with or without mitochondrial disease. You want to increase energy supply, obviously, and here's some of the things that do it. Decrease energy demand, and these are some of the things that do that. Protect against reactive oxygen species, because oxidative stress is a major part. And then, of course, treat the symptoms, such as I showed you some cases before, like with depression, you can use an SSRI like Zoloft, or anxiety. But you want to treat the symptoms as well. So I think of it as when you have, let's say, mitochondrial depression, you treat depression and you treat mitochondrial dysfunction. If you have mitochondrial pain, you treat pain and you treat mitochondrial dysfunction. But the mitochondrial dysfunction, sometimes you treat that and the problem goes away. So how can you increase energy supply? Well, exercise is really important. If you exercise too much, you go the other way. It's a double-edged sword. It has to be in moderation. And then these are dietary cofactors that you can get in the diet. And antioxidants, again, dietary supplements. So I took this from a really good paper that was from 2016, and here's how, if you just put this into Google, and you'll get it. And it uses acetyl-L-Carnitine, which is a form of carnitine. Two different studies that use acetyl-L-Carnitine, and both of those studies showed an outcome in ADHD that they improved. Zinc has 3 studies down here. 1 study showed no difference, and 2 studies showed a difference. I think that it might be that the one that showed no difference, it was 15 milligrams or 30 milligrams a day. The ones that showed a difference was 55, which is a high dose of zinc. And then the other one was 150. It's like, wow, no, that might be toxic. But anyway, it shows you the higher studies that zinc made a difference, and the one lower study, it didn't. There was a study using magnesium and B6. They work together, so they're often given together in studies. And then that study showed that there was improvement. What I want to show you is another study that showed that in ADHD, if you look at hair, that shows you not what you ate today, but your long-term, how much you have of the element in your hair over months. 78%, almost 80% of ADHD children had deficient magnesium in their hair, but only 21% of normal children. So it does appear that there is a magnesium deficiency in ADHD. There's been other studies that have shown deficiency in ADHD as well. Here are 8 studies on essential fatty acids. I know that that's hard to read here, but 6 of the 8 studies showed a benefit. So, overview, putting this together. ADHD is linked to oxidative stress. ADHD is linked to a lot of other conditions that are linked to oxidative stress, but there's a lot of evidence that ADHD has oxidative stress by itself. That suggests that antioxidant treatment may be helpful. Now, unfortunately, I'm not aware of studies that looked at high-dose antioxidants and of many different types in ADHD. I'm going to show you some studies and some other conditions. So we're going to have to look at this individually. L-acetyl-Carnitine, I showed you that there are 2 studies that appear to show benefit. 2 studies is not proof, but acetyl-Carnitine is fairly benign. It's over the counter. Magnesium with B6 appears to show benefit. 1 study, but it's also over the counter and likely benign. Zinc seemed to show benefit in 2 of 3 studies. Essential fatty acid, 6 out of 8 studies. There's been no studies of vitamin D and ADHD that I can find, but I did find a study that shows that vitamin D levels are lower in ADHD than they are in children without it. And there are many other nutrients that have not been tested, but are beneficial in other neurological disorders, such as autism and depression. And CoQ, folate, vitamin B12, and then again vitamin D are all improvement. There are several studies that show improvement in other related conditions. Now, copper levels are high in ADHD. I saw 1 study on that. Copper is a toxin in some cases. It's also an essential mineral that you can't do without. But it is high in at least 1 study, and I've seen studies in autism that it's high as well. So just giving all the vitamins at extremely high doses may not be the way to go. It may be a more intelligent approach is needed. A comprehensive approach, not to just supplement 1 or 2 of them, but to supplement the ones that are benefit, but perhaps to leave out the things that may not be a benefit or may actually be a problem. And then here is an excellent review. Antioxidants, vitamins, minerals, cofactors, these do not work in isolation. Energy is not made on enzymes which float in the cytoplasm of the cell, but enzymes which are docked on the membrane of the mitochondria. In fact, on the inner mitochondrial membrane, you can see that these enzymes are all in the membrane like an assembly line, one after another. So this is the Krebs cycle in the upper left corner. This is what you've probably learned in high school biology, perhaps in college biology. That's not what it really looks like. And this is the electron transport chain. You might have seen a picture of that. That's not what it really looks like. This is what it really looks like. This is an actual photograph, an electron micrograph. The colors have been made by a computer. They're not real. The colors are different to show you the different enzymes. This is an assembly line, start and finish. Here's a car assembly line. This is Ford, a turn of the century, over 100 years ago, and this is Hyundai recently. Energy is made on an assembly line. So let's say this guy right here is super energized, this one right here, super energized, and he's going to make cars twice as fast. Or this machine in the middle of the assembly line gets more power and is going to make cars twice as fast. You're not going to make cars any faster. You're going to cause chaos. The individual approach to nutrition is perhaps not the correct one, but you need to move the entire line. Others have thought about that. The ADAM study is related to autism. Like I said, nobody has done the studies in ADHD yet. But in the related condition of autism, that there was a significant improvement of a cocktail of 31 vitamins and minerals over placebo, which looked and smelled the same, but didn't have anything in it, really. But one thing I want to show you here, the improvements were in areas that are really important in ADHD, hyperactivity, tantruming. Those were some of the biggest improvements. Overall improvement, yes, but also language is often in ADHD. I didn't show you slides on that, but language is often affected as well. So there isn't a study in kids with ADHD, but ADHD-like problems can be helped. Now, Dr. Bonnie Kaplan has done many studies, and she's looked at a similar cocktail, which is different than the Adams cocktail. And she has found that patients with mood liability and explosive rage can improve dramatically in 2 case studies in children. Does that sound familiar? It's pretty common in ADHD to have that, as in autism. She's also found, as did the Adams study, that if you use a supplement that has a lot of different components to it, it's safe and tolerable. In fact, all the studies that I've seen on it have shown that these multi-nutritional supplements are extremely tolerable and safe. And to my knowledge, nobody has had a significant adverse event to them. If there are any side effects, and they're pretty rare, like nausea, they'll go away when you stop it, or you can reduce the dose or take it with a meal. So I got together with all of these other people as my advisors, and there's several other advisors that are not on this slide. And I've been talking to people as I've been crossing the country, first when I was at Cortigen for genetic testing, and now in Spectrum Needs and in my private practice and in the telemedicine practice that I have. And I've spoken to hundreds of different doctors that take care of patients with neurodevelopmental disorders, including ADHD, and designed a supplement which has 33 different components to it, but includes a very high-powered mitochondrial cocktail to it. So it's similar to the Adams and the Kaplan formula, but it has a higher-powered mitochondrial component than the ones that they studied. It has activated vitamins. The formulation has been made by a lot of people, including all of these. It corrects dietary deficiency, and it's made in the United States with good manufacturing practice. Comes in 2 flavors. Here's a label that shows you what the 33 ingredients are. It includes everything except for the fatty acids, the essential fatty acids that we've spoken about so far. So this formula is supposed to be complete except for the essential fatty acids. And then the amount that you give depends upon the weight of the child. And this is on the label, and it's also on the website. But I found that the CoQ is not enough. CoQ comes in 2 different forms, Ubiquinol and Ubiquinol. And the difference is in the last letters. Ubiquinol is the good one and has the L at the end. There's Ubiquinone, the other one in Spectrum Needs, because it's a powder and you can't put Ubiquinol, which is an oil. It doesn't work in the powder. So I found that I needed to supplement additional Ubiquinol form of CoQ, not Ubiquinone, in my patients because their CoQ levels weren't high enough and the benefit wasn't where I wanted it to be. So I was using other brands of CoQ, but it became problematic because many of these brands, you have to either go into the store to get the lower price brands, or many of them had soy in it. In fact, most of them did. So we came up with our own brand that's QNeeds, which is very similar to what I used to use. It's a tiny little gel capsule. It has limonene in it, which is the oil of a lemon peel instead of soy oil. And the bioavailability is great. My patients, their blood levels have gone up quite high. And in many cases, I could even cut back on the amount of CoQ. So I do recommend a Ubiquinol on top of Spectrum Needs, because otherwise you just won't get the CoQ levels in there and you just won't get the type of improvement. You won't get the full improvement. So I've been talking about energy the whole time, but I want to diverge in just a little bit to neurotransmission. Neurotransmission is one of those areas that's very important in ADHD. From the studies that have been done, it's important in autism, schizophrenia, depression, all of those conditions. The neurons have to talk to each other. It's not just good enough that the electricity can go from one end to the neuron. It has to communicate. So here's one neuron here. Here's the axon. It connects at the synapse to another one here. Now the synapse is the area between it. These neurons do not touch. There's a space in here. And when the signal gets to the end of the neuron, it causes these neurotransmitters in these little vesicles to fuse to the membrane. The neurotransmitter then goes into the synapse. And then it goes across the synapse and it binds to receptors on the next neuron. And that causes that neuron to fire. Well, that sounds really simple, but it doesn't really, that's an incredibly simplistic way of looking at it. Some neurotransmitters are excitatory and some are inhibitory. And a typical neuron in the brain will have 100,000 connections to other neurons. So that gives you something of the complexity. Some of those neurons are inhibitory and some of them are excitatory. And whether the next neuron will fire or not depends on the balance. The balance between excitatory and inhibitory neurotransmission is extremely important. Now, I haven't spoken about GABA yet. It's an inhibitory neurotransmitter. It's one of the two most important inhibitory neurotransmitters. The other one being glycine. And GABA interneurons. Interneurons are tiny little neurons in the brain that connect nerves that are very close together. They're sort of like, you may have a long nerve, and then you have an interneuron between that, and then you have another nerve. And the interneurons connect to them, and they are often GABA. But one of the things which is interesting is that these tiny little GABA interneurons are very sensitive to mitochondrial dysfunction. There has been many studies that have shown that, and we don't really know why. So that neurotransmission and energy metabolism are not completely separate. But if you have mitochondrial dysfunction, your GABA interneurons aren't going to work as well, and you're going to have an imbalance between excitation and inhibition. So think about it. If you have excitatory neurons that are going and your inhibitory neurons are not going at the same rate, you're going to be overexcited. You're going to have anxiety. You're going to have attention deficit because there's too many things to think about. There's too many things going on in your brain. You're going to be hyperactive. You're going to be impulsive. Many of these things are going to happen. So to a large degree, that there is an imbalance between the excitatory and the inhibitory. You say, well, wait a minute, why do stimulants work in ADHD? It's because the problem is not the excitatory neurons are not working. They're working just fine. They're not working too much. The inhibitory neurons are decreased. And the stimulants increase the inhibitory neurons to reestablish the balance. I know it's counterintuitive, but it's why stimulants work. So recently we made a product called CalmNeeds. It has GABA in it. It has theanine. Theanine it's not the caffeine, but it's the other thing in tea. It's what makes you soothed and feel good. And theanine also can help you boost GABA. And it has B6 and magnesium, which helps the inhibitory pathways work. And it has 5-HTP, which is 5-hydroxytryptophan, which makes serotonin. And serotonin is another important, serotonin dopamine balance is important as well. And then I often recommend, many of my patients will take one in the morning for anxiety, or they may take one at night to promote sleep. The only thing is that if you're on antidepressants that increase serotonin, it's probably important to discuss this with your physician, because if you're on very high doses of antidepressants, there could potentially be side effects. I have a lot of my patients on antidepressants. They're also on CalmNeeds. I haven't seen any problems yet, but it is important to discuss with your physician anything that you do, this being no exception. Okay, so this is the slide to try to put it together. These are my recommendations as to what to do in ADHD. First of all, Spectrum Needs. Yes, I am one of the originators of Spectrum Needs, and I have a conflict of interest, but there really is no similar product yet. There's the Adams one is not too much different, but Spectrum Needs is really the one that has all of the stuff in it, plus the high-powered mitochondrial cocktail in it. And I usually get blood levels. I like the carnitine, the free carnitine, not the total, to be higher than 40. And then all doctors have different ideas of how much 25-hydroxy vitamin D they want, whether higher than 30 or higher than 40. Every doctor has a different number there. Ubiquinol, which is a form of CoQ. There are other brands, but QNeeds is a good one. 200 twice a day, and anybody who's like first grade or over or so. Smaller amounts than the younger ones, and the preschoolers will often do 100 twice a day, and like the kindergartners, I may do 200, then 100. But the important thing is to check the blood levels 2 weeks later. I like the blood levels to be sky high. That's where I get the benefit, and I never see any side effects of CoQ. The only side effect I know about from CoQ is that it makes you dream more, and it can have issues with sleep. So about 5% of the kids take CoQ at dinner instead of at bedtime, because they have trouble with sleep. The other 95% doesn't matter at all. It's sometimes easier to do it when you go to bed to remember to give it. Spectrum Needs can over-energize, but that can, in a small percentage of kids, but CalmNeeds can go against that, or you can reduce the dose. And then anything you give by mouth can cause nausea. Spectrum Needs, about 90% don't have that, but there's about 10% or so that need to take it with a meal. So they take it with dinner again, breakfast and dinner, if they are in that category. Some kids have just queasy stomachs. Essential fatty acid supplements. Our company does not make one of those. There's many out there. There's many different brands. I usually use the recommended dosing in children that a lot of functional doctors do. Consider additional zinc. To bring the dose, there is zinc in maybe other things that you're taking. There's zinc in Spectrum Needs. To bring the total to 25 to 50 milligrams per day, and the bigger kids, maybe more like 12 to 25 in the children. Zinc is controversial. The study on zinc that I showed you, one of the studies used 55 milligrams a day. That's really basically 50. But it's different physicians think differently about how much zinc to give. And but one thing is that there is some suggestion that zinc makes it less likely that the coronavirus will enter cells and multiply. So I know a lot of my patients are taking zinc right now just because of that, and this is the dose that I'm recommending in the older ones, and half of that in like the elementary school kids. If you have CalmNeeds, it's different. CalmNeeds is taken if you have symptoms. If you have symptoms, then and it works great. On Spectrum Needs and Ubiquinol and everything, those are longer term treatments. You're going to see results. You see some results in hours to days, but you're going to see most of the results in weeks to months. And you want to keep them going to try to prevent the disease from getting worse and to try to keep the child in a good situation. CalmNeeds is something you can give as you need it. It's not something you need to give every day, or maybe if they have anxiety every day, giving it in the morning will help. Hyperactivity, insomnia. So this is a symptomatic treatment to work on GABA and on serotonin pathways. Now, the company that I belong to, we make products for dietary supplementation. We don't make medications, but in my practice and in my own child, I have a child with ADHD. ADHD is a serious condition, and it has ramifications that go throughout life. And you don't want to just halfway treat it. I strongly recommend that medications be used in addition to dietary supplementation, not one without the other. Now, if you have a mild case and the supplements work great, then good, great. I wouldn't give medication if the kid's normal or near normal. But if supplements don't work by themselves, and in many cases they don't, it's really a serious condition. I find that the medications and the supplements, that they are synergistic and they work great together. And disclosure, one of my own sons is on both and doing great on that. And, oh, by the way, when I take him off of the spectrum needs, because he doesn't believe dad. I mean, this is dad stuff, right? And what does dad know? I mean, he goes off of it and he gets worse. And so now I give it to him every night and make sure he takes it. He actually does a lot better on it. I had to have his doctor tell him to take it because he wouldn't talk to me about it. You know, teenager. Anyway, so these recommendations are general. They're not meant to circumvent and certainly not to contradict your physician's advice. It's recommended that all treatments be discussed with your physician. And everything that I said here is really important, that you just don't go it alone. And here are my contacts. There's NeuroNeeds and how you get to NeuroNeeds. And if you're interested in genetic testing or possibly for me to be your child's physician, then there are the contacts that are also on the slide. And thank you very much.